السلام عليكم ورحمة الله وبركاته جميعا. Thank you all for your presence. I really appreciate taking the time and effort to be there. For those who don't know me, my name is Mazen Baabdi. I'm a gynae oncologist by training, and I'm the residency training program director at King Fahd Medical City. The reason for this meeting today, we want to understand what are the new assessment tools that has been established by the Saudi Commission for Health Specialists to evaluate residents, to assess residents. By training, I'm not actually, I did not receive any medical education training, but I spent so much time in the last 1.5 weeks reading all about assessment and medical education, but hopefully I can present it in a way that will be easier to understand. Inshallah, we're not going to take more than 30 minutes. There are some videos that I'm going to give you guys the link so you can watch them at home. But the idea of this presentation is basically to help you understand the concepts. First of all, let's go throughout the outline of the presentation. I will share some housekeeping about the resident evaluations عندنا هنا في المدينة. بعدين هنتكلم about the residency program. بعدين the move towards competency-based medical education. What are the goals of the assessment and what makes a good assessment tool? But then we're going to speak specifically about the 3 workplace-based assessment tools that have been introduced. They're actually not very new, but now they are actually essential for any resident to graduate from a level to another. نبدأ بسم الله الرحمن الرحيم. This is a timeline of medical education by Dr. Andrew McNally. It's a very nice timeline actually to tell you how long did we start the residency programs. The story actually started in 1890, and more than 130 years ago, by a guy named William Osler. أكيد كلكم تعرفونه. He's a Canadian physician. He's one of the 4 founders of Johns Hopkins Hospital. His idea was basically you cannot train doctors just by giving them lecture at the university. You have to bring them to the hospital. So he introduced the concept of clerkship, bedside teaching, round, etc. Back to the medical education timeline, another shifting point that happens in 1910 by something called Flexner report. Flexner, Abraham Flexner, he's actually not a medical doctor. He's a private school owner. So basically, he was funded to go around all the medical schools in the United States and Canada. He actually visited McGill, where I graduated, and also he visited Toronto, to come up with suggestions and recommendations about the medical education. And his main argument actually that was we were producing a very large quantity of doctors, but the quality of doctors are not changing. And he came up with these recommendations. Some of them actually are still valid, and these are what actually started to shape our understanding about competencies. So basically, one of the most important recommendations he said that we have to train MDs in a scientific manner. And we have to increase the prerequisite for medical students to enter the medical school. And then we have to strengthen the governance of regulation of medical licensing. And the Saudi Commission of Health Specialists is one of these examples. But then Royal College in 1929 was established. But from 1910 تقريبا until more than the Second World War, until 1996. The medical education was mostly as what we call it as a tea-bag model. Yani you bring them the resident, you put them there for a certain number of time, depending on the specialty, and then a couple of years later, boom, you have your doctor. So it was entirely based on time, and sometimes only an examination at the end of that period that will qualify them to become a physician. Okay, so this is called the Miller Pyramid, and this is a very wide, actually, I don't remember any single paper or presentation that I've watched that did not talk about Miller Pyramids of competency that was established in 1990s. And basically, it sees knowing as only a first part of the journey toward competency, not as a final destination. I'm going to just give you an example. I think it's going to make it a little bit easier. So, for example, a cesarean section. Now, a medical student will come to you after his internship. He knows what is cesarean section. He knows about it. He knows some of the indications. But as he advances, like an R1 or R2, he will start to know how he does a cesarean section. He will know that, okay, you have to open the skin transverse, you have to go to the fascia, and then you open your incision on the smiley face on the uterus, blah, blah, blah. A couple of months or as he advances in the training, he will be able to show it to the assessors or the supervisor or the consultants, whoever. And then at the end, he will be able to do it with competently. Yani he will be able to do it by himself. تمام. In the last 20th century, there is like almost 20 years of scientific work. And when I went actually deeper into the medical education literature, it's almost like evidence-based. There are lots of studies, everything they do that has to be backed up with evidence. So basically more than 20 years of scientific work, and still we cannot agree among the scientific committees about what are the definitions of competencies, yet alone what are the tools that we can use to assess these competencies. So in the last 20th century, the formal assessment of medical trainees was almost entirely based on time, and at the end, a written test of knowledge. What we're trying to change actually in the last 20 years, that we want a competency-based medical education that not necessarily based on time or examination, but almost entirely on competencies. So we know that at the end of the road, we have to move towards a competency-based medical education. Still the way to go, we still have a long way to go until we reach that destination. So a competency-based medical education, by now, I hope you had some understanding about what is a competency-based medical education. But before we speak about more further about competency-based medical education, I want us to just try to imagine what would make a perfect competency-based medical education. So you need it to depend on the outcome. So not the process itself, it's the outcome that will give you a competent physician. And you want the competency to integrate knowledge, skills, and attitude. So you don't want somebody to graduate and he's competent only on the knowledge, but he doesn't have the skills or attitude, or he has two of them, not the third. So you have to have the three of them to become competent. And it is a continuous process, not something that ends, like, for example, it's not like when an R2 finishes his residency, his level at October 30th, all of a sudden he's senior and he's more competent. No, it has to go like a طيف, يعني, a spectrum. So from the start until the beginning, it's a continuous process, which is time independent. And it should be individualized. So for me to become a competent in something, for example, I would have to do something and see it like for 3 or 4 times to become competent at it, and then I'll be able to do it by myself. My colleague will only need actually 2 or 3 times. Another colleague will have to have it like 10 times. So it has to be individualized according to the trainee needs and adjust itself to a different need of different trainees. And it's not actually easy to understand the competency-based medical education and what are the frameworks that went into place to establish a competency-based medical education. But I found actually what I call the 3 pillars of the competency-based medical education. The first one is what we all almost know, the CAMED rule of competencies. The second thing is something called the milestones and the interestable professional activities. We're going to speak about each one of them separately. So the CANMED rule is the first competency-based framework that was established in 1990 by the Royal College of Physicians and Surgeons of Canada. Basically, it's a framework of competency that are essential to be an effective physician. And it's actually grouped into 7 CANMED roles to become a medical expert. As you can see clearly in their logo in the middle, you become a clinical expert. To become a clinical expert, you can see all these rules are actually intersect with each other. So you cannot have one of them separated or not integrated into the process. The CANMED rule is actually the most widely accepted framework of competencies around the world, and has been actually in many countries, such as Saudi Arabia, for example, who actually follow the CANMED rule of competencies. The second thing is called milestone, which is basically a specific expected abilities of the physician at a stage of the training. This initiation of milestone was also adopted. This is an example by the ACOG, American Congress of Obstetrics and Gynecology, of the milestone projects. To make it easier, I just put an example actually to understand it. So basically for each milestone, it has different levels, and it's more specific. I call the milestone to understand it actually better. It's the building bricks of a interestable professional activity that we're going to talk about later. So for example, in level 2, in a laparotomy, you have to perform a simple abdominal incision and closure, demonstrate basic skills in knot tying and simple suture. But then when you move to level 3, so a resident have to have a milestone at level 2 before we move to the next level, which is level 3. He will be able to perform uncomplicated gynecological procedure, recognize surgical complication, etc., etc. These levels are not meant to correlate directly with the level of training. So it doesn't mean that when you are level 2, you have to be at R2. No, it's actually the level of the milestone itself. So you can reach level 5 in any given milestone when you are in R3, for example, or R2. Okay. The third thing, which is actually I find it the most difficult to understand, which is the interestable professional activities. Basically, the idea of interestable professional activity is you can see it in your daily practice. Let's say if I ask you about Dr. X, and whenever you tell me that Dr. X, I trust Dr. X with my mother or sister, I will automatically understand that Dr. X is competent. So trust, in other words, it means competencies. These are actually more descriptive and supervised tasks and responsibilities that we entrust the trainee to do, and we tend to give them like a specific level for interestable professional activities. We start by observation, then direct proactive supervision, then reactive supervision, and then supervision as in distance, and then they will be able to do it themselves or actually train a junior. So in another word, just to make it easier, so each milestone is specialty or subspecialty, so will come with different milestone, and then each milestone will give you an indication of competency, and the aggregation of all these competencies will give you an interestable physical activity. Sorry, I tend to do say physical all the time, I don't know why. Professional activity, not physical. Okay. Okay. So basically, a competency-based medical education has these 3 pillars: the CANMED rules that was established in the 1990s, and then the milestone, which is actually integrated as well with the CANMED competency, but it is the building bricks of interestable physical activity for a physician, or for the trainee to become interestable. Okay, so the outcome-based approach Okay. Sorry. So basically, we have to have an outcome-based approach to the design, to the implementation, to the assessment, and to the evaluation of all medical education program using an organized framework of competencies. These competencies has used in the competency-based medical education. We use the unit of preparation to measure these competencies is knowledge, skills, and attitude. Okay, so make it easier. So basically, we know that to measure a distance, for example, use a centimeter. But in medical education, the unit that we have to use is, and not only actually on one thing, it's actually three things that goes all the time together, which are the knowledge, skills, and attitude. They call it the KSA. Okay, so the tool that you can use to measure the competency could be different. You could use a ruler to measure the distance, or you could use actually a measuring tape. So it's a different tool, but it's going to measure always the same thing. So that's why I want you guys to understand that the units that we're going to use in assessing competency is always the knowledge, skills, and attitude. And if we go back to Miller's pyramid, you can see that these three units are present in all the steps of the Miller pyramid. So even in knowledge, you have to also assess the knowledge, skills, and attitude. In showing how, you also have to assess the knowledge, skills, and attitude. Okay. We use actually some of these assessment tools. For example, in assessing how much the trainee knows, the fact gathering examination, the medical school test, the MCQ, and the essays. They knows how it's the clinical case presentations, and they shows how demonstrative learning, the famous OSCE assessment tool. And in DOS, which is the final step of competencies, we use the direct observation or the workplace-based assessment, which is the one that were actually introduced by the study commissioners now and being mandatory. This is also another overview of the assessment method that aligns with the Miller pyramid. As you know that we use the end of rotation evaluation, which is one of the assessment tools that actually focus on the final stage of competency, which is the DOS. And this is something good, but we need to also use some sort of clinical and direct observation in the clinical environment. I find this growth of competency craft very useful also to understand. So basically, in the residency, you see the trainees start as a novice and then advance and then become competent. We want the resident, when they finish their trainees, to become competent. So the growth over time goes something like this. So we start and you gain competencies and increases. We wanted to reach at a certain level when they are actually graduated here at the end of the residency. And then your competencies by nature, it's actually going to increase when you become a staff and then you become proficient. And then you become actually at the end an expert, and naturally your competencies will go down. This is the Sunnat al-Hayat. So we want to have the tools actually that will help us to assess each resident or trainee at a certain time of their residency, that we know that actually they are in gaining the competencies necessary to actually advance. So basically in the beginning of their residency, and then at the end, we want to make sure that they are actually on that curve and the curve is actually improving. So when they actually, their performance start to come down, we will be able to bring it up again by whatever intervention that we see necessary for a specific training. So I just want to give you this next slide. I'm just going to go through it quickly. Basically comparing what is the current system that we're using and what is the system that we hope that we're going to use in the future. Basically, an intern will come, they finish their junior residency program and then senior residency, and then they will have their final written exam. They will have the promotion exams after each year, and then also the in-training evaluation after each rotation, and then at the end they will get their certificate if they pass. But the future, the aim for our training should be actually like something that looks like this, which is basically we start with the orientation and the assessment, so we know what are the level of each trainee, with something like a portfolio, and then they start the foundation years with the core electives, and on the same time they were actually assist only with the tools that we are actually going to speak about a little bit later, which are the workplace-based assessment tool. And then they could have an exam, because still an exam, there is actually a value of exam. I don't want you guys to understand that exams have absolutely no value. There are actually some values for the exam. Let's say that about R4, and then after that, a transition to practice. And here where the final competency assessment is based. And then if he passed or she passed all this, she gets her certificate. So the evaluation is actually a continuous process since they start until they, and it's actually a continuous process of assessment and evaluation. Okay, so now we're going to speak about the assessment tools. Before we speak about these assessment tools, let's take a moment and try to understand what is actually our goals of assessment. This is actually a slide I took it from Dr. Jeffrey's slides. Basically, you want you assessing physician to have also motivation of capabilities of all learners. You want them to know where they are, and then you motivate them to improve, or even what if they are good to become even better. The second thing, we want to protect the public from incompetent physician. I want a trainee that actually finishes a training program that goes out and he would be competent to treat my daughter, treat my wife, treat my sister, treat my mother. So that's why we want to protect the public. The third thing is actually selection of best candidates so they can have an advanced training. Right. There are some criteria, like any test that we use to order us as a physician. Let's say you order a pap test, for example. You know what you have. This test has a specificity, positive predictive value, negative predictive value. But in assessing competencies, there are different criteria. The most important two, what I call the reliability and validity. It's very easy to understand if you define it this way. Reliability is the ability of the test to hit the same result every time you do it. So not how close to the target, but as actually the repetitive results over and over again. And then validity is how close your test to become very accurate, which is how close your test is to the target. The ideal situation is to have a test that has amazing reliability and amazing validity, which it actually does not exist. So hopefully I understood what is reliability and validity. And then you want the test has an impact of a future learning. And then you want it also to be accessible. It's not something that you cannot do, basically. The fifth thing is the cost. The cost is something actually important. And I remember I read in one of the articles that an OSCE examination, for example, which is a very good assessment tool, it costs $100 to $200 per resident, for example, in some university, which is actually a lot of cost that we have to think about it when we implement the assessment tools. So, if you want to have an assessment program, there are certain requirements that you have to have a best result in a competency-based medical education. So you have to use multiple methods. You can't use just one assessment tools and you want it actually to bring you the full picture of the training. You want to have a multiple assessor as well, not a single, because in this assessment tool, there is some area of judgment from the person actually who does the evaluation. You want to select, and also you want to train the assessor, and hopefully this is why we're here today. You want the assessor actually to understand, and the reason actually why I'm presenting this, that I want you guys to buy into the process or the change that we're doing. So it's not something that you have to do, but I want you guys to believe in what we are doing in terms of we want to assess the competencies. And we think, or sorry, not we, they think, the Saudi Commission, that these are the best assessment tool, and I do agree with them, okay? So there are some types of assessment tools. The two major ones are called formative and summative. So formative assessment tool, they are actually called ongoing process of learning. And it's actually not a formal test where there's pass or fail, but it's actually some sort of assessment. And a judgment of a teacher is always there in the formative assessment. The summative assessment is actually either any test that you, anything that you do that at the end there is pass or fail. This is most likely summative. And usually there are not much of the, there is some judgment, but the judgment is much less in the summative ones. They do sometimes intersect with each other. So for example, an OSCE, it has both of them. The one that actually, the observation one and the one that were established, sorry, the one was deemed mandatory by the Saudi Commission for Health Specialists are the direct observation assessment tool. The definition of it is actually the direct observation, anything that actually ongoing observation and assessment and documentation that occurs naturally as a part of daily clinical experience. Okay, it has some advantages and some disadvantages. Of course, the most important advantage is actually it is resembling to a very large extent what's happening in your day-to-day life. One of the most important disadvantages actually has some questionable validity and reliability. Then also the documentation that sometimes cannot be timely or they don't occur at the same time. So basically, to have a better assessment tool, you have to have a combination, as I said, of a different assessment tool. So you cannot take a single snapshot of a trainee and then you say, okay, I understand the whole picture of this trainee competency. You have to have a multiple snapshots of the trainee competencies to be able to build the picture at the end and to say, okay, this trainee has these competencies and this is his area of strength and these are the weak area that we have to work on. The Saudi Commission actually had said in their of the competencies, each resident will have to have 8 competencies, but I always say to my resident, this is actually a tool that you have to have for your training and you can almost certainly have much more than 8 per year for each of the competencies tool. So I advise them actually to do at least 16 for each tool, so we will be able to understand their level and they will be able to use it so what are these 3 competency direct observation assessment tool or workplace-based assessment tool to assess competencies? The first one called the clinical-based discussion, the second one called a mini CX, mini clinical encounter exercise, and then the third one calls the direct observation and procedural skills. Okay. طيب نتكلم على كل واحدة الحالة. We're going to talk about each one of them separately. The direct, the case-based presentation, it's an in-depth interview between a trainee and a senior trainer. Okay, it's cover a range of clinical problem relevant to the stage of the training and of course, the specialty here of obstetrics and gynecology. The focus of the discussion can be either one of them or all of these things: record keeping, clinical assessment, management, and professionalism. Okay. The main objective is actually not to focus on the clinical scenario that you're having. It's actually, and also not to assess the knowledge only. You have to think about this scenario as something that will open the gate for discussions and assessment of knowledge, skills, and attitude, giving the resident level, of course, and looking at it from different angles. Okay, so how does it work? Basically, a trainee will choose a case, any case, and then the trainee will explain the whole period of the case, examining what happened and why. So it's actually much clearer in the video, but the video is almost 15 to 20 minutes long. But basically, you're going to see that a resident came to the supervisor and was speaking about a case that she saw in the emergency. she was admitted, she had preeclampsia, and then she had PPH, and then she told him what happened and why did she did this intervention. He started to stimulate the discussion by asking about what are other measures to prevent this, and etc. etc. So the assessor will ask a supplementary question, as I said, and then both will make a judgment about the management, and then he will give her immediately or him the feedback. We're going to speak about separately about the feedback, but the feedback, as we said, it has to be timely, so it has to be at least the best feedback would be at the same spot. Okay. So the examples could be in case presentation, which is actually the best example when I say the morning report that most of the hospital actually does. A resident will speak about a case. One thing to remember importantly that all these assessment tools have to be individualized. So you have to do it in a one-to-one basis with the resident. So a case presentation in the morning or the morning report is good cases, but is not the place to do it when there is actually lots of other trainees and lots of other consultants. You have to do it separately with one-to-one with the resident. Okay. Sometimes patients in an outpatient clinic, when a patient sees, for example, a new patient in the clinic, she takes a history and physical examination and then comes to you and present the case. You can easily do that. I say, عندنا احنا مثلا في gynecology a new patient clinic, it's easy to do that in one of the clinic. Patients in an emergency, again, the same thing, managed during the on-call time. So there are so many exams they can do a CBD. The thing is actually to understand is these are based on a long, a long case, and you discuss the case thoroughly. Okay. This is a video. The link will be there with the presentation. We're going to see it together after we finish the presentation. So the next one is the mini clinical encounter exercise. So basically, this evaluates a clinical performance in a real-time setting of a clinical encounter. So mini, it is short and specific. So what are some examples of mini CX? Like history taking, for example. Medical interview skill, physical examination skills, professional qualities, counseling skills, clinical judgment. So it is very specific clinical encounter. When I say history, you could be, for example, with a trainee while he's taking a history from a patient that comes with intermittent bleeding, for example. Another example, let's say a patient came from emergency and now she's in the labor room. She's not progressing very well. There's some decelerations. You or the trainee by himself will say, can we do a mini CX in this patient counseling for surgery? And then you go with the trainee and let the trainee explain why and counsel the patient about cesarean section and etc. So many scenarios that you can do a clinical encounter exercise. And basically the way it works, and that the assessor or the trainee himself can choose a case and inform the trainee to do a mini CX. So you have to inform them that we are going to do a mini CX. And then the assessor will observe the trainee. So basically you do nothing and let the trainee do the encounter. Of course, if there's something really red flag that you have to intervene, feel free. The assessor will rate the performance of the trainee and then give some feedback. I say actually it's best that the trainee will send the electronic evaluation immediately within 24 hours of the encounter. And then the assessor will fill the evaluation form, and this goes for all the assessment tools. So this is a video that we're gonna watch. Right. The third one is the direct observation procedure skills. It's actually an observation and evaluation of a procedure skills performed by a trainee on a real patient in a real life. It has a good reliability and accessibility and high face fidelity, which face fidelity means actually how close is the examination to the real life. And as I told you, most of these actually are very close to the real life. The key feature of it is that the assessment it is actually assessment of a procedure skills, something you do with your hand, not you, the training. And evaluation of a specific patient encounter and performance procedure on actual patient, of course, and again, immediate feedback. I hope, and this is a video actually that we're gonna see about an example of DOPS. But hopefully by now we understand what are the different observational assessment tools that we have that are actually new and we're gonna use to make it easier, guys. A case-based discussion or CBD is something like a morning report. So think about like a long case, many clinical encounters. So basically it's a clinical thing. There's no procedure, but it's actually mini and small. So think about it like in the clinic, in a labor room, thing that are very short and has a clinical base to it. And then the third thing is the procedures, the DOPS, which is direct observation procedures. So it's a procedure. So think of it is a procedure. Like think about whatever they can do with their hand. Tamam. This table actually from the Saudi Commission of Health specialist. معايير الترقية في تخصص النساء والولادة. طبعا هذه المهارة والمعرفة knowledge, skills, and attitude. And basically, normally it would be 8, but given the Corona situation and the COVID situation, they actually broke it out to 4. So by now, hopefully you guys understand and convinced about the workplace-based assessment tool, which is actually a competency-based, moving towards a competency-based medical education. Before I finish, actually, I would like to speak about something very important, which is a feedback. A feedback is not about judgment or evaluating the resident in front of you. It's about actually giving an insight. Yeah, you give the resident things to think about. It is actually a skill that you can taught and also improve. Yani I'm 100% sure that when I started my senior residency and I started to give some feedback, my feedback was not as good as my feedback now, and I'm sure that my feedbacks in a couple of years will not be as bad as my feedback now. So basically, you have to train yourself to give feedback. Think about feedback as a ship that you're actually driving, and you want to bring the competency of the residents away from the danger zone, let's say, for example. So basically, you always try to give the resident an insight about what they are doing and how to change it. You're not judging them and you're not giving them an evaluation, especially in the workplace-based assessment tool. Okay, so there is no pass and fail in the workplace-based assessment tool. You're just giving them a good, or just giving them a good feedback that will give them an insight about what they're doing. So it's actually a reflection process. Usually, I always try to use a positive inquiries. There's a very nice book that's called Appreciative Inquiries that they use in assessing the economy of any given organization. And this exactly gives some sort of the same outcome here. Okay, so basically these are some hints about giving feedback. Usually try to make it descriptive, not judgmental. So try to describe what happened to the trainees. So for example, when I was seeing you doing a speculum examination, you did not speak with the patient or explain to her that you're actually going to introduce the speculum to the vulva that actually increases her anticipation, and then that's why she felt not so. So basically, you're describing what happened. Instead of saying, it's clear that you did not care about the patient feeling. So now I'm judging her in the second example, but in the first one, I'm telling her that no, these are the sequence of events, and this is why I thought and this is how you could improve. And believe me, many of our residents actually will buy or will benefit from giving a descriptive feedback rather than being judgmental. Okay. The second thing is that you have to be specific, not general. So, for example, if you are actually with a resident doing a mini CX and you observe that the resident was actually answering a different question to the patient's, you can tell him specifically, the patient said this, and then you replied with that. He cannot argue against it, actually. But if you said, you need to learn how to communicate with your patient, basically here, he could become very defensive. He could basically not buy what you're saying. Not even if he said okay, he will not be convinced, and he will not actually help him that much to change his practice. While if you be very specific, he will be able to remember it, and then okay, he will not gonna be able actually to argue against it. Okay. And they try to focus on a changeable behavior rather than the individual himself. So basically, for example, you need to allow the patient an opportunity to express her thoughts and not only be concerned about telling your thoughts on her condition. So this is a changeable behavior. So your thoughts should not be the main thing. It should be actually the patient's thoughts. While actually being individual, you can just say to the resident, you talk too much, which is not very constructive. Okay. The other thing actually that you have to emphasize the consequence. So basically, you have to, like the example that I told you in the beginning, you have to tell the trainee that by you not talking to the patients, when you were putting your speculum, you increase her anxiety, and then that's why she's expressing more and feeling more pain. So this is a sequence. Another example, actually, by not addressing the patient's medication concerns, you increase the chance of them not continuing taking their medication when they go home. So basically, trying to explain it to the resident in a way that it will stick more into their mind. Okay. The other thing is, which I cannot stress more on this, you have to be timely. I will not be able to evaluate or give a feedback to something that happens more than, for me personally, something that happened more than 2 hours ago, I would not be able to give feedback. And I'm sure for many assessors, anything that happens like in the last 2 or 3 days, you're not going to be able to give a good feedback. The feedback always has to be timely. You do your assessment, and then at the end of the clinic, you have to give the feedback. At the end of the day, at the end of the, let's say you have a very bad, very hectic on-call. At the end of the on-call, the feedback could take only 5 to 10 minutes and give the feedback, and that's it. Okay? And also focus on correcting the problems immediately. Okay. The last thing about the feedback, it has to be based on the first-hand information. So what you observe between you and the trainees. Try not to give a feedback about something that you've heard others saying about the resident. So an assistant come to you and okay, doctor, I saw that resident do this and that. And that way you're not going to be able to give a full constructive feedback. And this is actually called a hearsay. It's not actually a feedback. So it's not fair for the learner. And that's it. So thank you very much for attending today, guys. I really appreciate it. I hope by the end now that you understand what is a competency-based medical education and what is the assessment tool. In summary, that we are moving towards a competency-based medical assessment. And we have to have tools that will help us to assess and evaluate and improve our residents. And these are the 3 tools that we talk about. Think about it, guys, as in the management, they always use key performance indicators. Key performance indicators are not meant to be always good. They're meant actually to direct your assessment towards the trainee. And we know at the end, we want to move towards a competency where a competent of the physician that actually what's going to give them the certificate and bringing them to the public or the society. And thank you again. So please, the floor is open for all questions.